everybody.
Good morning.
Thank you. I love hearing that. And by the way, I was told that I have to smile because I don't smile enough at these programs. So if you see me while I'm talking, just cut out and smile. I'm smiling, okay? For those that don't know, my name is Stuart Schlossman. Many do already know me from the programs that we're doing in the state of Florida, as well as what you see me on Facebook or Twitter or on our blog or here or there, or speaking maybe for another company. A lot of people already know who I am, what I do, and why is it that I do what I do? Because I too have multiple sclerosis. I was diagnosed in 1998, and at the time, there was just not a lot of information for patients to find. Okay, the medical community was too busy treating and not wanting to just give us the information. So it was easier for me at that time. I was internet savvy to just get on the internet and find the information and be able to then to provide it to people at a support group that I was attending. So I was sending information to them every day, just 5 people, then 10 people, then 20 people. Support group leaders around the state of Florida started finding out the information I was providing, and they asked that I start giving it to them so they could forward it on to their groups as well, to their members. So what started off as just a little email list of sending to 5 people is now reaching people in 98 countries. Thank you. So, by the way, this is our 29th program of the year. I may have said it, I may not have said it. But yes, this is our 29th program of the year. We just got out of the state of Florida recently and did a program in Atlanta, Georgia. It was our first program out of the state of Florida. Our very first program where people out of this state could see the type of program that we do. What did it reward us? 167 people came to the program. Wow. That was a good turnout. And so we're going to now try to do one in Birmingham, another one in Charlotte. We're going to be applying for these grants to do these programs and get them out of the state of Florida as well, and also continue doing them in Florida. So we're going to try to just open it up to 4 states outside of Florida, get into Alabama, Georgia, and the 2 Carolinas. And that will be it for right now until we can expand further. And the only way that we're able to expand, though, is getting volunteers to help us out at these programs. We did not bring up any of our crew to Atlanta. It was just me and volunteers that we had in Atlanta. We had support group leaders come down and help us out. We also had the support group leaders on videotape. We also did it as a live webcast, which made them all very happy. And people around the world got to see me do what? Smile. Thank you. So that we had to do. All right? Before I go any further today, though, I want to thank Teva Neuroscience for giving us the grant to do this program today. So I want to thank Teva, and I want to thank those that support us. We could not do the education programs that we do, or now we're doing a wellness series as well. We could not do this without being able to get the grants from the pharmaceutical companies. They are allowing or enabling us to help to educate each of you with what is needed in an A to Z of multiple sclerosis. It is for people that are newly diagnosed, and we speak about many different things concerning the treatment options, MS relapse, MRI, symptom management, MS 101, and just going on and up. Adherence, compliance, the reasons for switching, when it's okay for you to switch, why you should be switching your medication. We bring in different secondary speakers. I shouldn't say secondary, but second speakers at all of our programs. We'll have either a neurologist or a psychologist or a neuro-ophthalmologist or a physical therapist, occupational therapist, something, though, that helps to allow you to learn that much more and let you know that you're not the only one with what you're feeling or going through as far as symptoms. So, I don't want to keep on rambling on and on and on here today. We have, in addition to Teva, we have other sponsors here today. We have Accorda Therapeutics. We have Biogen IDEC, Genzyme, a Sanofi company. We have Questcor Pharmaceutical. And we have MS Neurologist, who helps us at many of our programs. And many of you know NIDA. And NIDA's going to speak for about 90 seconds. And then we're going to ask...
That's it?
That's it. And then we're asking two other support group leaders to come up here today. But before I ask each of you to come up, I want to just give you today's format. Dr. Arnaldo Isa is here, and Dr. Isa will be speaking in Spanish and in English. Since this was supposed to be a Spanish program, we have to do some Spanish. Okay, and for those that don't understand Spanish, pretend like you do. Okay? Just say como. Okay? Or necesito a baño or something, okay? All right, so we're going to do Spanish, we're going to do English. And Dr. Konitzer, who's our psychologist, is going to speak about the impact of MS on the family. Okay, I'm sure he'll speak about something to do with caregivers as well. But all in all, we're all going to have a good learning day today, and then you'll be able to get out of here and enjoy the rest of the weather. So again, thank you for coming, and enjoy the program. First, though, we're going to have Naida, and then I'm going to introduce our other speakers. Naida, would you come up here and like to speak for 90 seconds? Sorry, I'm in the box. I got to be in this box, all right? But each of the support group leaders will speak for about 90 seconds, and then we'll get started with the program. Thank you again.
Hello, everybody. Like Stuart mentioned, I have a support group in Deltona. It is called the Msvn. I have some of my Msvn here. Some of the information on the group is outside. We meet the third Saturday of each month at the Deltona Library. Everybody's welcome. I have a newsletter that I mail to everybody once a month, so you will know what event I have for the month, and you're welcome to, to visit. Usually it's no RSVP unless we are going to a restaurant or something to get a number and have a space. What else? If you want the information, it's outside, and then I'm going to say something in Spanish because I'm helping a little bit store, as you notice. I'm from Puerto Rico, so I'm going to translate a little bit. Si alguien no entiende de lo que están hablando los speakers, por favor pueden luego preguntar, quizás hagan notas. Tenemos la ventaja que Dr. Isaac quizás luego les pueda contestar sus preguntas en español si les es más fácil. No tengan preocupación de preguntarle en español. Y si hay algún tema, quizás con el psicólogo, que les hace falta entender algo más, pues escriben una notita y después tratamos de entonces traducir y explicarles en español a los que se les haga un poquito más difícil. Si no, pues ya saben, habrán preguntas y respuestas y pues pueden hacer todas las preguntas que necesiten. Y de nuevo, the MS Catcher's information is outside, and thank you for coming.
Thank you, Naida. Next we have MJ from Daytona. Okay, so MJ, thank you. By the way, I don't know if I told you, the reason why we videotape is because there are people all around the world that do want to see our programs. And so, did I already say this? No? Yes? Okay, bye.
Hi, I'm Mary Jane, or MJ, whichever the day of the week it is. There are two programs in the Daytona Beach area, one at the Ormond Beach YMCA the first Sunday of the month at 1 o'clock. The other is at Disability Solutions on Palmetto Ave the third Tuesday of the month at 12:30. And everybody is welcome to those groups.
Thank you, MJ. Next, we have a lady named Lourdes, likes to call herself Lulu.
Good morning. This is my first time doing this, so bear with me. My name is Lourdes, or Lulu. I run the MS support group that meets at Winter Park Hospital at the at the library. We meet the first Sunday of each month from 2 to 4. I would like to welcome anyone who would like to attend. I will have some flyers outside. Thank you, and God bless.
Thank you, Lourdes. So, at this point in time, we do want to get started with the program. I see we have some new people coming into the room. We do have some chairs around. You may have to separate at this point in time. I don't see where we have two chairs next to each other. Oh, there we go. Okay, so you come right here. Thank you. You're going to have to go behind this podium, otherwise you'll be lit up on the screen. That would be like then you'll be in the airport where you have to put your arms up, Okay. Dr. Isa is here from the MS Center of Orlando. Yes. Come on into the picture here. We'd love to have you.
Great. Well,
thank you.
Well, thank you very much. Thank you, Stuart, thank you. MS Views and News, buenos días. Para los que hablan español, I was asked to give this talk in Spanish and in English. And a little bit about myself. I've been in the Orlando area for 15 years. We are a neurology group that's actually been established for quite some time, since 1981. And we have a very large MS practice, and we are involved in seeing patients with MS through all stages. And we've also been involved in several clinical trials, including the drugs we'll be mentioning here throughout the years. We also have a general neurology practice and cover or go to Florida Hospital Orlando. So we do a little bit of everything there. And again, thank you all. Let's see, what I need is to have my program set up.
Yes, thank you.
Yes.
Yes, thank you. Sorry, keep talking.
Right, well, what I'm going to start with is a discussion about meds. We'll review some of the older meds or first generation meds, then some of the newer oral agents. We can talk briefly about Tysabri. That wasn't really my initial intention. I will discuss the medications in Spanish and in English.
Down is forward.
Great, thank you. In Spanish and in English, and I'll just try to translate from sentence to sentence. Hopefully this won't be too confusing. I'll try my best to make this accessible to everyone. Okay, so let's see here. Multiple sclerosis. We'll try. Los tratamientos para la esclerosis múltiple comenzó en los años 1990. Como sabemos, la esclerosis múltiple es un desorden complejo que afecta varios procesos en el sistema inmunológico. Las terapias que existen hoy en día consisten de distintos mecanismos de acción, y la realidad es que no están bien entendidos. El sistema inmunológico es algo bien complicado que a lo largo estamos bastante claros que no lo entendemos muy bien, y poco a poco estamos tratando de entender este problema. To summarize the slides, treatments really only began in the 1990s from a practical standpoint. Of course, MS has been described for many years, in the neurologic literature from the late 1800s. It became more clear with Charcot's descriptions, and there really was no effective treatment up until the mid-1990s. It's a very complex disease with multiple abnormalities being affected in the immune system. And the therapies that we have, they're incomplete therapies. That means they're not curative, but they give us some insights into how to affect the disease for our patients. And they work through different mechanisms of actions. And the realities are those mechanisms of actions are really only partially understood. We don't really understand how each drug works fully. And the immune system is really complicated. And every year, it seems to get more and more complicated and very different than what I learned in med school. So things progress, and let's see. La primera generación de los medicamentos empezó con Bedaciran, aprobado en 1993. Es un tratamiento de 0.3 miligramos cada otro día. This was approved in 1993. Some of you might remember there was a lottery at the time that Bedaciran was approved in the in the early 90s. It was controversial, of course, because of the issue of access. There was a limited amount of production, and it led to a lottery. La lotería que tuvieron en el 93 fue controversial, pero a lo largo pudieron aumentar la producción del tratamiento y mejoró el acceso al público. Avonex came back next, had 30 micrograms every week. Many people are familiar with that. El Avonex vino después con 30 microgramos cada semana. Entonces Copaxone con 20 miligramos cada día, que existe hoy en día. Copaxone is what we also use, 20 milligrams every day. These are medications you're all familiar with, I suspect. Everybody here I'm sure, is quite educated in current therapies for MS. Y Rebidose vino después con dos formulaciones, de 22 y 44 microgramos 3 veces a la semana. So Rebidose came back later, 22 or 44 micrograms. It's also an interferon beta 1A, similar molecule to Avonex, but with a higher frequency. And over time, there's been some changes, han habido unos cambios. Hoy en día existe este tratamiento que se llama el Rebidose, que es una manera de inyectarse con un autoinyectador, que tal vez muchos los conocen. This autoinjector with the Rebidose got approved for use It's in an effort to facilitate the use and compliance with this medication of Rebidose. And of course, once one company comes up with something, somebody else comes up with something. So next is the Avonex autoinjector. El autoinyectador del Avonex también vino, está aprobado ahora para tratar de mejorar, to try to improve compliance. Ok, entonces en resumen, to summarize, la primera generación de los medicamentos mostraron en general un 30% reducción en el nivel de crisis o la tarifa de crisis por año con los pacientes de esclerosis múltiple. First generation drugs helped lower relapse rates by about 30% per year. Los medicamentos Betaseron, Rebidose y Avonex han mostrado reducción en progresión de incapacidad durante las evaluaciones de 2 a 5 años. The Betaseron, Rebidose, and Avonex have shown a reduction in disability progression, and all the drugs reduce MRI lesion loads, and they all affect the way our brains look on the MRI scan over time. Todos muestran una reducción en las lesiones del MRI que se encuentran. Entonces, las inyecciones, aunque ayudan y son efectivas para muchas personas, no son perfectos. Tienen sus propias complicaciones, efectos secundarios y, obviamente, como todo medicamento, no le ayuda a todo el mundo. So these are all partially effective treatments. They can have side effects over time, and this, of course, impacts adherence. And they're imperfect drugs. So efforts were made have been made and continue to be made to find alternatives. And I just want to stop for a moment and think that, you know, in 20 years, if you think about the progression of MS therapies, it's really rather amazing that for, you know, centuries, or at least, and certainly for at least a century and a half in the medical literature of knowing about MS, there's just absolutely nothing available for MS patients of any, you know, that was meaningful. And in 20 years, you've seen the proliferation of therapies that's really unheard of. I mean, I graduated in I finished my training in 1998. I finished my med school in 1992. And so really, during my medical education, we had no treatments. So it's really remarkable, even though I'm getting older, but I mean, it's really remarkable that even just in the 20 years that I've been out, to have this many options. Para mí es sumamente impresionante que existe tanto tratamiento para una enfermedad que por muchos años no había nada. Durante mi escuela no teníamos opciones ninguna para los pacientes. So it's been interesting to me that we have so many changes, and options. So let's talk about those. Okay, oral agents, pastillas que existen hoy en día. Seguro que todos han oído de estos medicamentos: Gilenya, Aubagio, Tecfidera. Estos son medicamentos que están aprobados para el tratamiento de la esclerosis múltiple. Y una infusión intravenosa que es Tysabri, que en mi opinión no es nuevo, es más nuevo que la primera generación de medicamentos, pero ha estado aprobado desde 2005. So oral agents have been approved in the last couple of years: Gilenya, Aubagio, and Tecfidera. Many of you, I'm sure, are familiar with these names. Some of you may be on therapy. And IV infusion, of course, is Tysabri. Tysabri is not really new in my mind. It's been around since 2005, but it is sort of the next treatment after the original injections. So Gilenya comes in a capsule, pinkish color, 0.5 milligrams daily. Esta es mostrándote la Gilenya, la pastilla de 0.5 miligramos diario. Esto ayuda a mantener las células linfocíticas dentro de los ganglios linfáticos. So what this drug does is it binds lymphocytes, which is our white blood cells, the cells that are key to mounting the immunologic reaction and attack against your brain and your spinal cord, and it keeps them locked into your lymph nodes. So that leads to a reduction in circulating lymph nodes, circulating lymph cells, and we think that that's part of the reason it reduces the complications with our MS relapses. A little bit about this response rate. Se realizó 70% de los pacientes después de 2 años que no habían tenido una crisis, y menos pacientes tenían incapacidad, 18% contra 24% en el grupo de placebo, sin incapacidad progresiva. So this was effective in both relapse rate reduction and disability progression. And when we talk about medications for MS, we're really looking, or the measurements you hear about all the time are MS relapse rate, MRI changes, and then disability progression. And those things are the three variables that up to now have really been the key features that have been reported to the FDA that helps people understand whether or not this drug is somewhat effective. And these have all been placebo-controlled trials. Los problemas con Gilenya, que puedes tener efectos secundarios, principalmente es que te baja el pulso, puedes tener problemas con problemas cardíacos, en algunos casos requiere una reevaluación de riesgos cardíacos, un electrocardiograma, y requiere que uno esté bajo observación por 6 horas después de comenzar la primera dosis. So, unlike a lot of medications where the doctors will prescribe something and send you out, these new medications really require a lot more monitoring. So Gilenya, for example, the biggest issue here is the potential for a lowered heart rate. That requires an assessment of your cardiac risk factors, an electrocardiogram, and your first dose requires a 6-hour observation period in a medical facility. That could be in our office, for example. We do first dose Gilenya evaluations. It could be in a walk-in type of a clinic. Urgent care centers have offered themselves, cardiology offices, etc. And there's a protocol about how to observe patients. One of the things you'll notice with this discussion is that as therapies for MS become stronger in some ways or different in some ways, the effect on your immune system and on other organ systems is going to go up. And that's true, I think, of all medicines. All medicines, as they get more sophisticated or maybe more complex, you're going to be dealing with more variables to think about. So, other complications, otras complicaciones incluyen edema en la retina. Oops. Puedes tener problemas con los enzimas del hígado, problemas con los pulmones, y te aumenta un poco el riesgo de infecciones. So, complications, macular edema, that requires you to get an eye exam before you start Gilenya. Liver enzyme elevation, you need to get blood work done before. Lung dysfunction, it's pretty uncommon, but you can get some problems with shortness of breath on Gilenya. That's something to be aware of. If you start the medication, you start to have problems with shortness of breath. And then there's increased risk of infection because you're lowering the circulating white blood cells. So again, as you modify the immune system and try to have a positive effect on your MS, you're going to be affecting or altering your risk for having other problems. And that's the trade-off in all of medicine, all conditions. We're constantly balancing risks versus benefits. There's nothing, nothing in life is free. You always have to assume some risk in any treatment versus the benefits of that treatment. So, and that's a really important understanding, I think, for patients when we talk about switching, and we'll talk about switching in a few minutes, but when you start talking about switching, you always have to, I tell my patients, you always have to ask yourself, why are we switching? And sometimes, you're switching the devil you know for the devil you don't know. So you have to think really hard about why you're switching and what are you looking for? What are the goals of switching? And what are you hoping to achieve by switching? Switching to something that's new just because it's new is generally not a good idea across the board in medicine. I don't care what you're treating. I think that's generally a very true statement. You switch because there's a goal in mind. And I think that's very important. So if you forget everything that I'm going to say, and you may forget all of it, but try to remember that. It doesn't matter what you're doing in medicine. When you make switches, ask yourself, why are we switching? And if it's just because this is new, that's a very bad reason. And that pretty much applies to everything. I don't care what disease it is. So ask yourself why you're making a switch. Antes de comenzar Gilenya, requeremos varias información. Tenemos que saber el electrocardiograma, Si tienes anormalidades de la conducción en el corazón, problemas del laboratorio, una evaluación por un oftalmólogo para tener por lo menos una base de cómo anda la retina, si vas a tener problemas. Tenemos que chequear anticuerpos para la varicela. Tenemos que repasar los medicamentos. Y posiblemente vas a tener que ir a ver un cardiólogo. So, before you start Gilenya, you need to get an EKG, labs, eye exam because of the small risk of macular edema. Macular edema is some swelling behind your retina that an ophthalmologist can evaluate you for if you develop it. You need to get checked for chickenpox antibodies. Make sure that you've been exposed to chickenpox before you start Gilenya or get the vaccine. You need to review medications. Meds that can affect heart conduction may be something to either modify or may prohibit your desire to start on Gilenya. And depending on how complex the patient is, you may need to see a cardiologist before you get started on Gilenya. Now, many patients with MS are relatively young and healthy outside of their neurologic condition. So a lot of this stuff tends to be pretty straightforward. But every now and then, there'll be people where they'll have to get more extensive evaluations. If you're seeing your doctor and he's requesting a bunch of tests before you get started on one of these, this drug, there's a reason for it. And the reason is because we have to double check for these problems. Aubagio came out after teriflunomide is the drug. It's 14 milligram tablets. Aubagio se aprobó después, 14 miligramos, y también de 7 miligramos la tableta, aunque 14 miligramos sería la dosis más común. Y también es una cápsula chiquita, es a small capsule, blue capsule. Y también se aprobó en 2012, aprobada para 7 y 14 miligramos diarios. Hubo un cambio de reducción de un 30% del relapse rate o de las crisis anuales que tiene el paciente, comparable con las inyecciones que existen hoy en día. Y la dosis de 14 miligramos también bajó la probabilidad de progresión de incapacidad para el paciente, aunque eso no está aprobado por el FDA. They have a 30% relapse rate reduction. I was just saying, very similar to the injections that we talked about earlier, and delayed in disability progression. So, although technically this is not part of the labeling from the FDA, but there was in the trial a reduction in rate of disability progression in these patients. Entonces, problemas con Aubagio, cosas para considerar. It's category X, es categoría X para el embarazo, que significa nunca se debe de utilizar en un paciente que esté embarazado o que puede estar embarazada. So category X means this is not a drug to be used for pregnancy. When you think about pregnancy drugs, they have like categories A, B, C. Most drugs are category C, which means maybe a problem. You have to weigh it out comparing to the risk of treatment versus non-treatment in the pregnant patient. This is a category X drug. You cannot use this in pregnancy. Many patients with MS are females. Many females get pregnant, so it's something to consider. How's that? Oh, yeah. So it's something to consider in a discussion with your doctor. Are you likely to get pregnant? Are you anticipating getting pregnant? So these are important things. Are you using reliable birth control? Those are really important issues because of this. Este es el tema. Puede durar hasta 2 años en la sangre. This can last a very long time in your bloodstream, unlike most drugs. So, what all that means is you have to be aware of that, and there is a way to accelerate the removal of the drug. Hay una manera de acelerar el metabolismo del medicamento si estás anticipando un problema con el embarazo o que se embarazó sin querer. You know, my experience as a doctor is that most people get pregnant in unexpected ways. I mean, it's very common for me to tell a patient, I'm gonna start you on this drug, don't get pregnant, and then I got a call 2 weeks later, I'm pregnant. So that happens all the time in medicine, and so, especially with my epilepsy population primarily. So this is something to be aware of. Liver problems can occur with Aubagio. Puedes tener problemas del hígado. You're gonna require monthly liver function tests for the next 6 months while you're on the medication at least. Aumenta el riesgo de infecciones. You can have increased risk of infection. Y tienes que chequearte para si has estado expuesto a tuberculosis. So if you've had previous tuberculosis exposure, there's a need to get checked. And the way we check that is a blood test, or also you can get, I don't know if anybody's ever gotten what's called a PPD, where they put a little injection underneath your skin just to make sure you've never been exposed to TB. You can be exposed to TB and never had tuberculosis. That's not uncommon. That's just something to be aware of. So again, each drug has benefits and each drug has its side effects. So again, the take-home message here. And then the last drug out here is Tecfidera. It's got a big name, dimethyl fumarate. All these 9 words got big names here. Sometimes I could barely keep up with it. So it lowered the annual relapse rate by 53%, slowed disability progression by 38% compared to placebo. Pretty good numbers. Started 120 milligrams twice a day, then slowly increased to 240 milligram tablet twice a day. So this is a twice a day medication. The other ones were once a day medications. Let's see here, sorry. Wait, hold on one second. Entonces, para los que en español, reduce el relapso de 53%, baja las tarifas de incapacidad por 38% comparado con el placebo, empieza con 120 miligramos 2 veces al día y se aumenta a 240 miligramos 2 veces al día después de un tiempo. Efectos secundarios, side effects. Puedes tener, wow, this is going to be a tough one, so I would appreciate the audience flushing in Spanish. I haven't had a chance to think about that one. Lo que pasa es que se como sobrecalienta la cara, la piel se pone rojo, but that's not one word flushing. I'm always looking for the one word translation. I don't know how to describe flushing in Spanish. Dolor de estómago, diarrea, elevación de las enzimas del hígado, igual como todos los medicamentos. También te puede bajar los glóbulos blancos, te aumenta un poco el riesgo de infecciones, puede durar hasta un año. So flushing is your skin gets red, skin gets hot, you feel very uncomfortable. It can last for a while, usually manageable. Most side effects are manageable, but it does occur. It's just something to be aware of. Abdominal pain and diarrhea are common complaints. Again, something one can work with, but they are common. Elevated liver enzymes, lower your white cells. White cell counts can go down by about 30% and can last up to a year. So again, we're modifying the immune system. We have consequences of modifying the immune system. Something to be aware of. Stuart talked a lot about education. And part of this whole process, hopefully, is educating individuals that treatments have a very real effect on your body, and you just need to be aware of what those effects are. It's not things to be scared of or, dramatic about. You just need to be understanding, what are you taking, why are you taking it, what do you need to watch for, and that's really essential. And I think sometimes that gets takes a back seat, to all the hype of a new treatment and a new therapy, and that doesn't always. You really have to pause and think hard about what you're doing and why you're doing things. I'm going to stop here for a second and talk. Voy a parar aquí un momentico y hablar sobre el concepto de cambiando medicamentos. ¿Por qué cambiaríamos de las inyecciones, que son los tratamientos tradicionales, a algunas de las pastillas? Bueno, hay varias razones. Parte de la razón es que el medicamento no le está funcionando. Medication switches. Why do we switch from traditional drugs to these newer therapies? One, we feel like the medication is now working. And number two, we can't tolerate the medication anymore. People get tired of the medication for whatever. They have side effects or intolerable side effects from the medication. So if someone's doing very well on an injectable therapy, first-line generation, high functioning, no side effects, doing well, they walk in the office, do you think I should change their medications? No, right. You should never change their medications. Like I tell my patients, who are doing very well, you can't get any more sort of normal than normal. So if you're doing well right now, then you're doing well. So why would we change for? So why would you consider changing? Why? So you're having more disease progression. You're having more relapses than what would be expected for you. You're having intolerable side effects. Those are those are reasons to consider. Possibly MRI changes that are unexpected with the therapy that you're on. You start to develop more and more lesions and more symptoms over a short period of time. Those are reasons to consider switching. I think that probably a lot of, in my own personal practice, switches are being driven by tolerability issues. And so, again, can you manage those side effects and the tolerance? And what are you switching towards? And how confident do you feel that switching the patient is going to make a difference for the patient? Because you could switch somebody to a new therapy and then they have more symptoms. Then you haven't done them any favors. The big problem with treating MS, as I'm sure all of you guys have realized, it's a very, unfortunately now, very reactive therapy, which means you put somebody on a medicine, then you watch them over time, and then later in time you make a decision. And it's not like treating blood sugars or blood pressure where you could put somebody on a pill, check their blood pressure next week and see, well, it seems to be working, not working. You can make a really rapid decision. You change a medicine, you got to wait several months and assess whether or not you think it's making a difference in their lives. So it's challenging in that regard. MS is very challenging in that regard. Hopefully in the future those things will change. We'll be able to better predict who's got a good response to one drug versus another drug. But that's a whole different topic. And I would just add, we could talk about any of these drugs, mechanisms of actions, or side effects for an hour. So I've tried my very best to try to go over everything relatively efficiently, recognizing that this is not going to be a comprehensive talk. So let's try. I did want to mention one other thing that I failed to mention. So people who are on Copaxone, which I didn't have on one of the slides, there is in the works a formulation of double dose 3 times a week. So that'll be a modification. Va a haber un cambio con Copaxone de 40 miligramos 3 veces a la semana, que va a ser un cambio de lo que uno está experimentando en estos momentos. Eso tal vez le va a hacer un poco más fácil la vida a ciertos pacientes. So be aware of that possibility. All right. Let's talk about adherence. Adherence means you're sticking to your medication regimen or your overall treatment regimen, right? So why is adherence important? And adherence is important not just for MS, but it's important for all the patients that I see, multiple sclerosis, epilepsy, Parkinson's, neuromuscular cases. Adherence is important because therapies are designed to have an impact over time. Most of the stuff we deal with as neurologists are long-term diseases. We don't see a lot of patients with a sprained ankle, and we give them some anti-inflammatory and wrap their ankle and they go home and everybody's better in 5 days. That doesn't happen in my, some days I wish I had a job like that. Yeah, but I don't have a job like that. So adherence is key because it's the long-term. Like I tell my patients, when I see them in the office, I'm telling them, and then having a new diagnosis and a new crisis, I'm thinking not, are they going to feel better next week? Because I have no idea if they are. But I'm trying to think, what's the trajectory? Where am I pushing these people towards? Where they're going to have a positive trajectory over the next 3, 5, 7 years? Because that's really what you're thinking about. MS is a lifelong disease. So the horizon, the treatment horizon, is a different one than what most people are used to. Most of us still, doctors sometimes, and certainly patients, and people who are outside of medicine, have a feeling that the sort of the acute, sudden treatment, the things we're familiar with, a hurt bone, a sprained ankle, an infection. And these are different diseases. These are long-term diseases, and you're trying to establish a trajectory for the patient. How are they going to be looking 5 years from now, 3 years from now? Can you get them on something they can stick with? So why don't people stick with medications? Well, the big one is this one. I feel fine. Well, I had this thing. It went away. That was a year ago. Why are you wasting my time telling me about side effects and all these medicines I got to take and all these scans? I don't have any problems, so I don't want to take anything. The problem with the brain is you can't look inside your skull and see what's changing in your body. And so, I tell my patients, if we had like some growth on your hand that you could see every day when you woke up, it would motivate you to say, okay, I've got this problem, I got to treat it. But in the brain, it's silent. You don't see it. You can certainly have side effects and complications, but so you have to believe that you're buying into a treatment for yourself, even when you're feeling well, and that can be very challenging. So adherence, it's a lot of psychology. I teach residents, and I often tell them that being a doctor in a lot of ways is like doing sales, because you have to convince people that you are providing for them the service that they want and getting them to buy into what you're selling, sort of basically what you're selling them, that you're the right doctor for them, you're giving them the right idea, and you're giving them the right treatment. So they have to believe that there's a right treatment even when they're doing well. Crisis treatment is a horrible way to practice medicine. It's a horrible way to manage patients, and only come and see me when you have a problem. That doesn't work. I hate shots. Anybody in the room have that? Oh, yeah. Yeah, somebody. Okay. So I hate shots. A lot of people hate shots. Shots stink. Nobody likes it. Again, though, the diabetes population has been grappling with shots and injections for decades. So humans get used to shots. Those of you who raised your hands, you can get used to shots. So the original kind of immediate rejection of injections for injections, you have to kind of work through that. You may be able to tolerate it at some degree. You may be able to get used to it. You may not. I'm just saying. But I think an immediate refusal of treatment because of this alone doesn't, you have to work through that. That doesn't make sense. Too expensive. This is legitimate. These are expensive products, very expensive products. This is, to me, a very legitimate concern. And the answers are complicated. We have a very complicated healthcare system in America, and I don't have a simple answer. No one does. There are very many patient assistance programs that are available. There are some alternative funding sources for patients. I would say that in general, most of the therapies, or at least one or two of the available therapies, are usually available to our patients, even in the most restricted, financial conditions. So that's been my experience. We can usually find something that can get covered. Too many side effects. Well, that's a very real barrier to adherence. Too many side effects. So part of that is trying to find out, what are the side effects? Can you modify the side effects? Can you find some way to deal with the side effects, right? And then this is the hardest one. I'm not getting better. That's a very difficult one. That's one of the real challenges with treating patients. Your goal is to try to make people better. And with some neurologic diseases, not getting worse is a type of success. And that psychologically is a very hard hurdle to jump over as a physician, to try to convince people to stay the course if they're stable, if they're not getting worse, that there's progress in that. Because the natural history of a disease is for it to get worse. But people get tired. They're like, why am I doing this if I'm not getting better? I want to get better. Unfortunately, these are imperfect treatments. They're incomplete treatments. And they don't always have a simple solution. But those are all variables. This kind of ring a bell with anybody, or everybody, or some of the people here about what makes it hard to try to stick with the program? Right. And so because of that, there's been some alternative therapies, and there could be some more alternative therapies. I mentioned briefly Tysabri. It's a once-a-month infusion. I didn't go into it in detail. I certainly can. If somebody has any questions during the question and answer session, I'll be glad to answer some questions about that. And it has a whole list of variables you have to, but it is convenient. It's once a month. It can work well for some patients. The pills can work well for some patients. But these are important issues of adherence, how to stick with a drug, because that's the only way that these drugs are designed to do. They're not antibiotics for a sinus infection. They're just not. And this isn't treating a sinus infection. It's treating a lifelong disease right now until we establish some way to cure it or really arrest it, stop it in its track. You're kind of in it for the long haul. We're in it for the long haul. All right, so we're going to shift gears. I was asked to give some talks about meds, symptoms, adherence, many things. I'm smiling because I could probably talk about any one of these things for an hour, but I'm trying my best. Here. So, symptoms. Anybody have symptoms with their MS or no? Yes, yeah, I know. Everybody has symptoms with their MS, and it all varies. So here's some rough estimates, though. So sensory disturbance, very common. About 2/3 of patients with MS can have sensory disturbance. Cognitive problems, concentration, attention, focus, about a 1/10. It's pretty common. A lot of people forget that because you can't see that as easily. It's something that patients might notice, something that their caretakers might notice. Vision problems, up to 40%. Dizziness, instability, 20%. Pain, about 20%. Bladder problems, 10%. This is probably an underestimation in my opinion. I'll probably say more like 20 to 30% of my patients eventually develop some difficulties with bladder. Muscle spasms, weakness, walking difficulties, half the patients. So there's a lot of problems with MS, a lot of symptoms with MS. So what we talked about beforehand was treating the disease process, the immunological disorder that's affecting your brain and spinal cord, some of the newer therapies that are available. With the goal that if you treat those things well, hopefully patients will have less of this to contend with. This is a direct function of neurologic injury and damage. Everybody got that, right? So the reason you get these symptoms is because you have injury to your spinal cord, injury to your brain, and that's why we struggle. So let's talk about some of these symptoms. Let me see how I'm doing on time here. Fatigue. Anybody feel run down with MS? Many of my patients struggle with fatigue. Fatigue is a tough one. How's that? Common, 150%, right. Fatigue is a tough one for a lot of different reasons. The biggest challenge with fatigue is it's a difficult symptom to have for a patient to have and for a doctor to conceptualize, because there's no measurement of fatigue that one can see, right? It's an experience. It's an internal experience of fatigue or listlessness. And so you can't take a picture of fatigue. I can't have you step on a machine. You could just spend $1 million on MRIs. You're never going to see fatigue on an MRI. So fatigue is really a tough one. It's tough for the patient. It's really tough for the doctors too. But one thing I'm going to start when we talk about these symptoms is one of the important things about treating patients with MS, and I think that you need to share with your doctors, is that patients with MS are not, there's no rule that says you can only have MS and you can't have other problems. So for each of the symptoms, I'm going to mention alternative explanations for the symptoms that have nothing to do with MS. And it's important when you go see your doctor to go through, could it be something not MS related? I tell the residents, when I teach residents that, I tell them all the time, when I have doctors send me patients, and I see patients for medical problems that has nothing to do with MS, I'm constantly explaining to them that you can have MS, you could also have gallstones. So you need an ultrasound of your belly. You don't need to see me. And so unfortunately, the MS patients, oftentimes everybody gets sent back to the neurologist for everything, and they may have nothing to do with multiple sclerosis. So what causes fatigues? Things to think about: thyroid disorders, B12 deficiency, untreated sleep apnea. Poor quality sleep remains the primary cause of daytime fatigue. So it's important to ask about sleep hygiene. Are you able to go to sleep? Are you able to stay asleep? Do you snore? Could it be that you have sleep apnea? Could it be that you have some other problems? Poor quality sleep causes fatigue. And treating this can improve your fatigue, and it has nothing to do with your MS. Anemia, medications, many medications, cause dizziness, sleepiness, heavy-headed feelings. Multiple medications have a multiplier effect, and that can create side effects. So take a look at your meds. Can you get rid of something? I joke that my primary job is to get rid of meds, not to start meds, because so many patients have so many symptoms because of medications. But if after all this we feel it's predominantly or most likely or most reasonably explained by multiple sclerosis, there are some medications which are off-label. Off-label means it's not approved by the FDA, and as you know, I'm sure your neurologist have told you, if you can't prescribe off-label as a neurologist, you might as well not wake up and go to work, because everything we do is off-label. So modafinil, amantadine, methylphenidate, which is a Ritalin, fluoxetine, which is Prozac, one of that generation of antidepressants, have all been looked at for fatigue with MS. But it's important to think about other medical problems. Depression. Depression and mood disorders are very common with neurologic conditions all over. Depression is actually quite common just in the United States in general. So, causes. Depression is another tough one. It might be a new onset, adjustment to a new diagnosis. It's a life-changing diagnosis. It changes your lives, it changes your family's lives, it changes interpersonal relationships. It makes you think a lot, like anything that changes your life, makes you think a lot about what the future holds for you, your mortality, etc. That can be difficult and overwhelming. Thinking about medical causes, hypothyroidism, a couple other medical causes that can cause depression. Medications, interferons definitely can be associated with depression. That's something to review and discuss with your doctors. Narcotics can cause depression. Benzodiazepines, which are drugs like Valium, Klonopin, Xanax, those drugs can also cause depression. Things to think about: counseling, medications like Prozac or Celexa or any of these other many antidepressants that are currently available for the treatment of depression. But the take-home message is Is there a medical cause not related to MS? Could the medications you're on be contributing to depression? And then you have to decide what's the best course of action. So, medications don't make you have MS. You still have MS. Like I tell my patients when they have a lot of stressors at home, we talk about whether to start a med or not, depending on the stressor. These meds don't pay your bills. These meds don't make your kids behave better. These meds don't improve your, relationship with your spouse. They may be appropriate, they may not be appropriate. Sometimes this is better. It just depends on the situation and how the person sees themselves. And there is a value in this. And so I certainly prescribe them, but you got to think about everything. Spasticity, leg stiffness is predominantly the issue. You could certainly have arm and stiffness on one side of the body or the other. You could also have leg stiffness, so spasticity. So spasticity has to do with increased tone in the muscles. In our muscles, there are stretch receptors. And what that means is as a muscle moves through its range of motion, it sends a sort of subconscious signal to the spine to let the spine know how it's moving, and then we have a reflexive reaction back to the muscle to make it move. And what happens with MS and other spinal cord diseases, traumas, et cetera, that we deal with, is this reflex loop is disordered, and there is a hypersensitivity of the information coming in and a hyperactivity of the information going out back to the muscle, which straightens the muscle out, stiffens it, and you get contraction of the muscle. And then what's happening is that there's a breakdown often in these other little nerve cells called interneurons that help manage that signal. So it's, too much information comes in with an immediate reaction to stiffen the muscles, and that leads to spasticity. And there's often ways also for our brain to influence this phenomenon. And what happens is if you have spinal cord lesions, the signaling from the brain can't get down into these areas of the spinal cord, and patients struggle with spasticity. Treatments include baclofen, which has been around for a long time, tizanidine, Ampera, which is a newer drug that's been approved for improving walking in patients with MS, stretching, conditioning, physical fitness, all those things are really helpful for our patients. But spasticity is a major problem. The only other thought I have about spasticity to mention is if you think your spasticity is getting worse, you might have, for example, something like a urinary tract infection. I don't know if you guys have heard that if you get infections, especially urinary tract infections, it can often make your MS symptoms worse. That's what we call pseudo-exacerbation. That's not an uncommon phenomenon. So again, it's important to take a step back and say, what else might be going on here? Do you really have a new lesion, or do you have something else medically that's altering your spasticity? Physical discomfort can affect it. And again, conditioning, exercising, stretching, that's important. So everything's important. Pain. Pain is common with multiple sclerosis. So let me start by saying I am not a pain physician. I think pain work is very hard. Pain's a complex phenomenon. There's physical factors for pain. There's a lot of psychological factors that influence pain, how we experience pain, how we deal with pain. Pain's often, multifactorial. But if you have it, again, we try to establish, is this a pain due to something directly related to MS? Or is this a pain that's related to some other condition? So you could have MS and have a pinched nerve in your back, like a disc problem. You could have MS and have degenerative knee problems. You could have MS and have neck problems. So you can have rheumatoid arthritis. There's no rule that says you can't have something other than an MS problem. So it's important to double check. But if ultimately it's felt that it's principally related to your MS, meds that we routinely use are the tricyclic antidepressants and the anticonvulsants. And these drugs have been used for many, many years. So common drugs here would be like amitriptyline, nortriptyline, Cymbalta, which is duloxetine. Anticonvulsants would be like carbamazepine, gabapentin, which I'm sure a lot of you have heard the word gabapentin, Lyrica. These can be these are drugs that can be very helpful for pain if we think it's ultimately neurologically based pain. But again, always taking a step back, what else might be the cause of pain? Putting someone with leg pain on gabapentin because they have hip problems is not going to make them better. So you have to make sure you identify what the etiology or the cause of their pain is. The other issue with pain management, which is very challenging, is you have to understand that pain management is often different from being pain-free. It is uncommon to have a patient with a neurologic syndrome and pain to be pain-free, and I don't personally view that as a realistic goal. And part of treating individuals and working with your doctor is setting expectations. And so I think pain-free is not realistic, but trying to find a way to manage the pain to improve the patient's day-to-day level of activity and quality of life. And that's really the challenge with treating pain, is how to assess the patient's quality of life. And sometimes very aggressive pain management, in my experience, is sometimes associated with a reduction in the individual's quality of life because the meds are so heavy. You ask the patient how they're doing, and really you realize they're not doing much. I mean, the pain becomes a central focus, interpersonal relationships deteriorate, and their ability to sort of have any enjoyment is very low, and yet they're on just tons of medication, so it becomes very difficult to know what's the right course. My general approach in those is to get on less medications. Most people do better with less meds, regardless of whatever we're treating. Sexual dysfunction, that's something that's not talked about a whole lot, probably because most doctors don't want to talk about it. Or the patient, or, I mean, it could be awkward. It's interesting how, even as a physician, I treat a lot of people, but I mean, I get uncomfortable with it sometimes, depending on how it's brought up and what, like how much information is being shared. Sometimes I'm like, too much, yeah, no, but so sexual dysfunction is important. It's often underappreciated in patients with MS, patients with chronic neurologic conditions. So what are some of the things? Sexual dysfunction can be related to having spinal cord damage. You can notice erectile dysfunction in men. You can have lack of sensitivity to your perineal area is kind of your private parts. So you can have a reduction in sensitivity that can lead to anorgasmia. Anorgasmia means the inability to reach an orgasm. That can affect, for females, lubrication. It can be related to a poor self-image. I mean, a lot of sexuality is psychological, how we see ourselves, how we see our partner, how we interact with one another. And so, poor self-image affects one's libido. It could be related to stressed interpersonal relationships. So again, I mean, that's a common problem. That's got nothing to do with having MS. That has to do with, living with other people. I mean, interpersonal relationships are just part of life. There could be physical limitations. The individual may simply have a hard time engaging in intimate acts because of some sort of physical limitations, and there may be some reluctance to discuss alternatives, maybe outside of someone's comfort zone, maybe outside of someone's, tradition about how they view themselves, so it's something to consider. And an important one, again, medication side effects. Medication side effects are really, can affect libido. Antidepressants can affect libido, pain meds can affect libido, seizure drugs can affect libido. So it's important to kind of take a second look at all this and see, when did these problems start? Is there any solution to these problems? There are medications that can be tried in some of these cases that could be helpful. Limiting medications could be helpful. But some of it, can also be related to taking a step back and thinking about this is something that needs to be discussed and needs to be reviewed with your partner. So I think I'm done. I don't know the time we have right here. I go about 12:40. So, oh yeah, sure. I think we'll do Q&A at the end. Okay. All right. After. Okay. Sure. Okay. Very good. So I'm all done. I think there was going to be a break now, Stuart, before the next speaker, or not?
I didn't know you were finished. But firstly, I want to thank Dr. Easton for coming here today, because I like the format that you did. A little of this, a little of that. It was great. It worked out really well. Thank you. Thank you. It definitely wasn't boring. I mean, it was very interesting. I even understood you. That was even better. Como? Yeah. Yeah. So we're going to take anybody need a break? Or are you just more comfortable with let's just continue on here. I'm more comfortable with this. If we start all getting up and shuffling around, you know, it'll be a nightmare out here, right? All right, so next I want to ask then, next I'm going to ask Dr. Konitzer. Nida, just so you know, we're doing Q&A at the very end. We're not doing that right now.
Okay.
You don't have to worry about that microphone yet.
Are you going to wait for the psychologist?
The psychologist is here.
I know, but why you don't finish looking for...
We're going to do the Q&A after both speakers.
Oh, okay.
Okay? So we're going to ask now Dr. Justin Konitzer, and I forgot where you're from. You could give us a little bio of yourself very quickly, all right? I didn't bring it with me, I'm sorry. I must have been left at one of the other programs. But in either case, I'm really looking forward to hearing about this. I'm sure many of you as well. This will only be in English, so if you don't understand English, you're going to need a translator. And no, I can't supply that. But Nida will do it, okay? Dr. Konitzer? Thank you.
You'll pull up my slides.
Yeah, I'm going to do that right now.
Because I
before
have
forget
my
the next
little-
one. So
yeah.
you just give a quick bio of
Yeah,
yourself,
sure,
and we'll go
sure.
forward from there.
Sure. Well, hello, I'm Dr. Konitzer. I will do a very quick bio, and part of it is in the slides where I come from now. I'm currently at the Orlando VA, and I work in primary care mental health. I'm not your traditional psychologist in the sense that primary care mental health is a newer subdivision of mental health that the VA is championing. And you're seeing it everywhere. It's health psychology applied clinically. And so I see patients who come into primary care. Oh, perfect. Thanks. I see patients who come in to see their primary care doctors for whatever you go to see your primary care doctors for. And as you would imagine, I see a whole host of conditions. From folks, you know, looking to cut back on tobacco and alcohol, all the way through folks with chronic conditions, mental health conditions and medical conditions. And so in my role, I have to be able to work with all sorts of conditions and all sorts of people. And so in that context, I do see MS at the VA, and I see quite a bit, I think. Prior to that, I worked at Eastern Virginia Medical School in a similar context, and I saw MS there. And so that'll be the brief of it. I can go back and back and back, but I think that suffices to say I know kind of what I'm talking about with relationship to psychology and MS, at least. Dr. Issa did an excellent job covering symptoms, and I have a little bit of coverage of that here. So I'm going to move quickly through that so that we're not too redundant, and maybe add a thing or two relating to psychology there. So, okay. So I don't know. I know that many of you are recently newly diagnosed with MS, and many of you are not. You know, I've been to a couple of these, and I see that some of you know one another, and so there's a tight-knit group here, I think, and others maybe not. It's your first time. So excuse me if I talk to things that you are already experts on. That's great. Then you can pass this along to other people you interact with that aren't, all right? And again, some redundancy with Dr. Issa, that's okay. So general overview of MS real quick while we get into the psychology aspects. Immune-related disorder of the central nervous system, you can read like me, I think, even from back there, so I won't read these slides. I do want to talk about white matter plaques, inflammation, and something called demyelinization or demyelination. Plaques become active and cause flare-ups, and these flare-ups you probably talk about as flare-ups or exacerbations or recurrences or whatever, and those are primarily what produce the symptoms proper of MS. Here's an estimate, and I've seen many different estimates. This was about a year ago, 50 per 100,000 people diagnosed with MS, and I believe that's in the US. More common in women than men, as you probably already know. And interestingly, for a chronic neurological condition, for what I've dealt with, at least in dementia and other things, symptom onset is relatively young here, right? We know that you might get your first experience of symptoms in as early as your 20s. And that's something that not a lot of people are aware of. Or teens, yes. Yes, thanks. Yeah, this is the common onset, 20 to 40, or some say 20 to 50, but certainly teens, yeah. Okay, so a brain cell. This is what I work with in psychology, the brain primarily, and we know the spinal cord is connected to the brain, and that's relevant. I'm going to quiz you on all this, and this... Oh, no, I'm serious. So, get out your pens. But really, when I used to teach this stuff, to oversimplify here, the myelin sheath are the parts of a nerve cell or a neuron that we're most focused on with MS. And an easy way to remember that, just for your own edification here, is MS, myelin sheath, right? The acronym there. So the myelin sheath is basically the fatty substance that covers a brain cell, okay? And it covers the part of the brain cell that's like the wire that sends the message to the next brain cell and the next brain cell and so on. So it's an insulation and it's extremely important. If I told you that the myelin sheath is primarily responsible for speeding up the processing of your brain cells. So I ask you to think on your feet, I ask you to talk real quickly. All of those activities require processing speed to be real fast. And it's the myelin sheath that helps you do those things quickly. So if MS primarily attacks or is a function of demyelination, what kind of symptoms do you think you might see when the myelin goes away or gets attacked?
Very sight.
Very what?
Very sight.
Yeah. Yeah. And yeah, a general slowing, right? A slowness of movement, slowness of thought. And I like to talk about slowness in general, as you'll see in a minute, as being really underlying a lot of other symptoms. We'll give them different names, but really you can almost argue they're all part of this slowness, okay? Especially memory. So quiz later. So I was asked to talk about the impact of MS on the family, primarily. And it's really difficult to do that in 20 to 30 minutes without giving a little context. So I want you to look at this, and here assume this is an individual with MS. It's many of you in this room, perhaps. You have your own psychological being, your own physical being, right? The word cognitive here and throughout just refers to thinking skills. If you don't know that word, just think. Okay? So we all have our own thinking and emotional systems as individuals, and that's going to be impacted by MS for sure. We'll talk about that. But we exist within a larger network. Okay, obvious stuff. We have families, we have work life, some of us, we have leisure lives and social lives, and they're all interconnected. So really to talk about MS is to talk about MS in the family, is to talk about MS in you at work, and MS in you in your leisure activities, MS you in your world. Not just limited to you. How many people, by the way, just quick show of hands, I know you're eating, how many people are with at least one friend or family member today? Okay, I should ask it the other way. Is there anyone in here newly diagnosed or even perhaps not newly diagnosed with MS who came alone? Okay, so about 3. Okay, so the vast majority of us are with a friend or family, and there's a couple without, all right? We don't have a choice. Okay. Well, maybe you're going to make some new friends today.
Yes.
Okay? All right. Impact of MS on the individual. Stuart doesn't want me to talk about this. He wants me to talk about impact of MS on the family, and we will. But real quick, we need to know how you're going to cope and feel and deal with this as an individual first, because that will impact your family. So here we go. Dr. East has already covered these, but thinking symptoms vary within and among people with MS. I can't stand up here right now and tell you what your course of cognitive or potential memory issues or thinking symptoms are going to be. I can't. It varies extremely. It varies as widely as the plaques vary in your brain. Memory is one of the most common cognitive complaints, and the severity of memory impairment does not correlate with severity of neurological symptoms or of duration of illness. Interesting. The worse you get, do not conclude, physically, let's say, that your memory is going to decline, in correlation to that. Not necessarily the case. One of the things I want to say about memory real quick. How many people have noticed you have some mild memory problems that you are now attributing to your MS condition? Okay, some-timers? How many people can tell me from those folks you do not see a steady memory decline, but rather you have moments that are more or less worse than other moments, okay? That's the vast majority of it, okay? One thing to think about, and I did this experiment in a class once, it seemed to work. You think about that slowing, that myelin sheath going away, that slowing. If I were to ask you this, if I were to say, I want you to do this math problem in your head and produce an answer and give it to us, okay? If I said I want you to add 3 plus 10, multiply that answer by 5, subtract 2, and then multiply that answer by 8, how many people? Okay. I don't even remember the. So one thing that I've noticed, I've had some friends with MS that I haven't worked with professionally, but so I get to interact with them much longer than I do with a patient. What I've noticed is just because you are processing incoming information a little bit more slowly than the person next to you does not mean you're dumb, right? And it doesn't mean that you necessarily have a memory problem the way that I typically talk about memory problems as damage to the hippocampus or Alzheimer's disease or something like that. It might just mean that because you're processing information a little bit more slowly, you either will get the remembrance, but it will come later, or you won't get the remembrance and therefore conclude you have poor memory because it just took you longer to process the early information, and by the time I'm giving you the new information, you're still dealing with processing the information that preceded it, okay? Maybe not really memory as much as just a function of your slow processing speed. What does that do for you? I don't know. I want you to walk away knowing that it's not necessarily the case that because you feel like you have memory problems, you are also going to be someone like Alzheimer's, like an Alzheimer's patient who will lose your memory progressively as you age. That's not necessarily the case. And those with Alzheimer's, if you're in the room, you're not necessarily going to lose it at a certain rate either. Fatigue's very common. Dr. Issa did a nice job getting into detail about that, so I won't. 30 to 50% of patients with MS will develop mild memory or cognitive impairments. I say mild, okay? And it's estimated that 20-30% will develop more significant memory or cognitive impairments, all right? Here's the good news, though. 20 to 50% will not develop cognitive impairments at all, or may have fleeting symptoms, okay, but not enough to constitute over the time course of their condition significant memory impairments. So let's focus on those good news statistics as much as we focus on reality with the other statistics. Okay, other motor cognitive impacts. I'll spend 3 seconds here because we went through them already. Just take a look at the list. Maybe there's a couple that there's a medical term here that you didn't know, like dysarthria is slurred speech. You can just kind of pick up some language terms here. Okay? Paresis. Dr. Issa, do you have a better? General weakness. Hemiparesis is weakness on one side. Okay. All right, so you know all the sensory symptoms. Good, well, you got a new word. Okay, so emotional impacts on the individual with MS. You're eating, but if you can close your eyes for a minute, that might be useful. And I didn't bring my music with me, but imagine the doo-loo-loo-loo. We're going to go back in time with your eyes closed or open. Remember when you were a kid? No? Remember when you were anywhere between age 5 and 8? All right. Do you remember this? You can open your eyes now. Anyone in here want to admit that they had a significant fear of the dark? I'll admit it, okay? Maybe you don't remember. Significant fear of the dark as a kid. It's funny because a lot of kids have significant fear of the dark. A lot of them. Not all, but a lot. Why is that?
Can't see.
Can't see. But if I close my eyes, I can't see, and I'm not significantly fearful.
Imagination creates things like shadows turning into monsters.
Your imagination creates things from reality, sure. Yeah. Shadows and monsters. Any other thoughts? That's true. It's an interesting thing that all human beings have in common, that little kids show us in this moment, in this fear of the dark, that we share in common. What's that? Yeah. Who said that? Two of you back there. Unknown. More generally speaking, right? We walk the kid back to bed and we comfort them and we say there's no monsters in the closet. But what are they really afraid of when the lights go out? At a deeper level, at a human level. And we all carry forward, whether it's the dark or what our finances are going to be post-collapse. You know, it is the fear of the unknown. Yeah. We don't know what's in the dark. We can't see what's there. We don't know it. So we're afraid of it. Human beings need predictability. We need a lot of things, and one of them is predictability to function at our emotional best. And so rather than starting with depression, I'm going to say numero uno for a newly diagnosed MS patient or newly diagnosed patient with any condition, chronic or not, you're going to be anxious, right? Because you don't know what's around the corner. You don't know which one of the 4 subtypes MS you might develop when you start getting educated. Once you know what that type might be, you don't know when the next flare-up's going to be. You don't know where you're going to be when you have a symptom and how embarrassing that might be, right? This is something that I think we all share. It's exacerbated in MS, I think, a little bit more. Depression does occur, and again, Dr. Issa did a nice job of getting into some of the emotional symptoms here. Approximately 25% is the estimate I have of individuals with MS. And let me say this, there are 2 main types of depression. There's a reactive depression and a depression that may be more of a direct consequence of the condition itself or where the plaques establish themselves in the brain. People with strokes or MS or other conditions that directly affect the brain can have those effects happen in certain parts of the brain that actually physiologically will initiate a depression. But certainly the type that I'm more used to dealing with and helping patients cope with is the first, the reactive. This is, I'm anxious because I don't know when my symptoms are going to return. I'm anxious because I don't know how that's going to impact my loved one. And I'm anxious and I'm anxious and I'm anxious. And here we are at year 2 and here we are at year 3. And if I carry around this level of anxiety up here for that long, I'm going to get depressed. Because it's depressing to be anxious that much. So that's kind of a cascade that seems to be typical in the work that I do. Euphoria, something that might be mistaken in the psychology world as like maybe a bipolar condition. Someone might feel extremely elated suddenly with a mood that goes through the roof. Happiness, it's almost uncomfortable. Euphoria happens in a relatively large proportion of folks with MS, and it's fleeting or it can recur. So often it's my task to figure out, is this another condition or is it just euphoria as part of MS? There's a quote there. What does it say? One patient, bedridden and unable to stand, remarked, "You will not believe me when I say I feel thundering well." Interesting, right? With all the fatigue and physical symptoms, that's how the emotion was. Other major emotional impacts that don't get really discussed often, I think, are those that deal with loss. Okay? Loss. And I always like to say loss and then pause because that's the feeling of it. Something's deep here and it's going away. When someone passes away in our lives and we feel that sense of loss, some of the emotions that come with that are interesting and not really intuitive. You would think you would be sad for sure, but would you be angry? Why would you be angry? You just lost someone. You're sad, right? Why would you feel guilty unless you were part of that losing someone? I don't know. But yeah, denial, anger, fear, and I didn't put guilt on there, but guilt should be on there, are all feelings you can have about your own self after becoming diagnosed with MS, or even after becoming diagnosed with MS, managing it well for 2 or 3 years, having a relapse, having something else in your life on top of it, external, and all of a sudden you feel like you're back to square one and you feel like you're losing your sense of self, who you are as a person. And it always gets somber when I do these talks. I want you guys to know, just like Dr. Issa, with sharing some of the more difficult challenges of MS, These are also areas that we can target to make your lives better. That's the point in talking about some of the difficulties and challenges. Now we want to go in and attack those. Okay, so an individual with MS, there we have it. Remember, we have their whole constellation of being in their life. And I want to zoom in now. Let's see if I can use this. We talked about the individual and the symptoms, cognitive, emotional. And let's talk about family life for the rest of the talk. Unfortunately, I could talk for 2 hours up here and we can go into each domain, but I think family life is extremely important here. I like this idea that chronic illness is not a disease of the individual, but rather diseases of the family. I like that idea. For all of you who brought family and friends here with you today. Again, you live in a network. You do not live alone. Pre-existing underlying difficulties can be exacerbated by MS. Of course, we know in the individual you have some other condition, hypertension, or you're just depressed before you ever had MS, and that's going to make it worse, sure. But pre-existing conditions in the family can exacerbate symptoms of MS. And MS symptoms, in turn, can exacerbate pre-existing difficulties within the family. I'm talking about family dynamics and roles. There needs to be, with a chronic illness diagnosis, a lot of role shifting. And I'm seeing a lot of heads go, yes, because you've experienced this already. Who's going to do the physical tasks around the house anymore if dad comes down with MS and we don't necessarily want dad on the 20-foot ladder around Christmas time hanging lights around the chimney? Not on, maybe he can, but not on one of his days where he doesn't feel well. Okay? Maybe Christmas lights don't get done this year. That's kind of sad if we have to shift like that. Or maybe someone else in the family takes on the role. Maybe someone else, a friend new in the family, enters the family unit. Any way you look at it, you get the point. Major role shifts. Be prepared for those shifts, and if you're a family member and a supporting family member, instigate those shifts where appropriate. Have a talk at a new diagnosis or at a turning point in the course of the illness where we get together as a family and we say, hey, look, we've noticed this and we would like this, and this to start happening. How can we help? What roles can we shift here to make this work? This is one of the biggest issues being talked about in research, actually, across illnesses. I deal a lot more probably with Alzheimer's disease, admittedly, than MS, but caregiver stress and burnout is huge, okay? And it hadn't been talked about in the beginning, and when I say in the beginning, in the earlier years of these, if you go back and read, we were just so focused on the patient. We're learning so much more now, studies constantly being put out on caregivers alone. They don't even care about the patients in these studies, right? It's about what is it like to caregive for someone with a chronic illness. It's tiring. You have to go through a role shift. You may lose some of your own previous identity. You may develop the emotional symptoms just like the person with the illness, like depression and anxiety. The old adage is, if you can't take care of yourself as a caregiver, how possibly could you take care of your loved one suffering with the illness? And in fact, it's arguably the case that you might even make their illness worse. And it's not my job to spread guilt here, but you really have to think about this. If you are at your wit's end and you are not giving self-care to yourself as a caregiver, and then you come into a situation where you're attempting to caregive, and it instigates an interaction that's not useful to either one, we're both going downhill now, right? So we've got to take care of our caregivers. It gets really sticky now, right? I'm seeing a family, okay, we're going to focus on the caregiver. Well, what does that make the patient feel like? Oh, I'm the one with MS, and here we are focusing on Janie? Well, what the heck's going on there? I need my sympathy. I need my attention. What's that? It's hard because we're humans and we're full of emotions and it gets complicated. But, you're right. We all need the care. As soon as we can let go of those defenses and say, it's not necessarily about me, I'm within a system, as much good that I get from my caregivers, I also need to turn around and allow them to take center stage of care, then we're going to all be healthier. Yeah. 50% of individuals with MS are dependent on help from a close relative, is a study I read the other day. I would think it'd be higher, but maybe I think in the study they had friend caregivers as well, and they didn't include that close relative definition. I like this image here, teamwork, when we're talking about caregiving. All right, if you look over at the left, it's a little blurry, but I'll describe it. They're playing video games in a store, it looks like, and there's no chair, and the boy in the red sweatshirt, the boy in the red sweatshirt's like, little Jimmy, can you be at my chair, because I really want to play this game. And so Jimmy's the little chair for a while, and guess what? Jimmy's back gets what? Tired. Jimmy's the caregiver for MS. Jimmy's back gets tired. So Jimmy says to the person with MS in this analogy in the red shirt, well, dude, why don't you lay down and let me and be my chair, for a little while. And so now the caregiver's supported, right? And this is kind of just a quick image way to think about what has to happen. If we can go through cycles in our family unit of, do I need to walk into the square or talk over to this side?
Inside the square.
Okay, I don't want to cover the screen here. Thanks, Stuart. What would we do without Stuart? Thank you. So here we go. Just keep this in mind, guys, right? You got to care for the caregiver. You really do. You got to turn the tables and be the caregiver's seat. Does that mean, am I saying you, the individual with MS, has to turn around and care? Yeah, a little bit. You got to be understanding of their burnout. But what I'm going to shift into now and probably end on is a discussion of getting professional care and making sure you keep that caregiver in the bigger picture. A couple more bullet points on impacts in the family. Emotions related to loss in some or all members of the family, fear, anger, guilt, okay? We did it in the individual level a minute ago, but you have to understand everyone in your family unit may begin to feel a sense of loss. You're not going to like probably my last bullet point, but it is a reality. Picture a kid in a family of a newly diagnosed individual with MS who is, let's say, 35 and she's a mother. Maybe a mother of 2 kids, right? 2 to 7-year-old child really doesn't know much. They certainly don't know much about MS at this point. Okay? A generic statement here. You can read that on your own. Those dynamics that are changed can really create other barriers to living your life. Okay? You all used to do the beach drive, every Sunday, and it's hot. And maybe your loved one just thinks it's too hot today and I don't want to go to the beach. But beaches are a family thing. We do them every Sunday. Well, maybe not this Sunday. And maybe there are kids involved and the kids really want to go to the beach. It changes the system. Children of individuals with MS may have fears, embarrassments. This is the one you're not going to like. There's newer research out about this. It's not just anecdotal. Kids of all ages, I gave you the 5 to 7 age, but even as you go up into early high school, if mom and dad are coming to your basketball game and, maybe mom or dad comes with some sort of assistive device for ambulation, a cane or a wheelchair, and kids at age 12, really, we think their frontal lobes are starting to more fully develop, and what comes along with that is just a better sense of empathy, a better, deeper understanding of complex problems and relationships. So 12 to 15, but still any teenager, we know them, right? They're lacking a little bit in the wiring up there. Maybe it's not until 18, 20 that it's fully wired. So even your loving 13 to 15-year-old adolescent child might be embarrassed of you. They don't want to tell you that sometimes, but they might be. And we can't hide from those realities. Right? We really can't. Why not address them in some kind of professional way, starting in the home, addressing them, and then if we need professional intervention, we get it. But these are the realities of the family dynamics when you're dealing with chronic illness, especially something that may be visible like an MS or another condition that might have physical impairments associated with it. So shifting here now, what can be done? Individuals with MS and their families should be open about their thoughts and feelings. Again, a simple statement, right? I know that's simple. You didn't need to come hear me say that. But the fact of the matter is people struggle really hard to be open. The little child that you have doesn't want to tell you, Mommy, Daddy, I'm embarrassed. So maybe it's your job as a person with MS to bring everyone in the family to the table and say, look, I know what I have and it must be hard on you all. Let's talk about it. Focus on what you can do as opposed to what you can't. Classic, but very important psychological concept. The world is how we frame it, really, right? Do we feel privileged when we look at some third world country situations, no matter what condition we have, medical or emotional otherwise? Do we feel privileged? Well, it's from our perspective of being Americans that we gain that sense of privilege. It's from our frame of reference. We can put up any frame around any picture that we choose, right? And so if we choose to focus on what we can do instead of dwelling on what we can't, or what we can is a strong word, what we may be limited in, then waking up in the morning and getting ready to go do something I know I can do or do with assistance is a lot better than waking up in the morning and sitting on the couch and saying I can't do that anymore. Like Dr. Issa nicely said, when we're looking at pain in any condition, our goal is not to go on that, pain scale with the faces. You see that, doctor's office? It's not to go from a 10 out of 10, which, by the way, I need to take this opportunity. No one's a 10 out of 10 if you're in the doctor's office. All right, I'll recalibrate you. 10 out of 10 is supposed to be you are incapacitated on the ground, can't move. How did you get to the doctor's office that day? An ambulance must have brought you on a stretcher. Just so you know. But if you're an 8 out of 10 or a 7 out of 10, most of the time, the goal isn't to get you down to 0. If Dr. Issa could do that, or his colleagues, then they'd be extremely wealthy. The goal is to get you to a 5. Isn't a 5 a heck of a lot better than a 7? And then maybe down the line we'll get to a 3. That would be acceptable and increase the quality of my life greatly. So the same thing here. We're not looking for perfection. We're not asking you all to be, I have to make this reference, Jack Osborne. No. Do you know that one, right? Yes. The Dancing with the Stars guys. Okay, he's out there and he's got MS and he's open with it and he's dancing on the Dancing with the Stars. That may not be for everyone, but making movements toward that and focusing on what you can do is extremely important. A couple more thoughts here. Do what your primary care doctor says, even if you don't have MS. This is a bullet point list here. Engage in healthy lifestyle behaviors, exercise, social connectedness, cognitive or thinking exercises like reading, writing, and games are all important for your overall well-being, no matter what you have. Caregivers, family members alike. Do not underestimate the power. I've seen articles come across my desk in the last 2 months like you wouldn't believe on exercise and Alzheimer's disease. The thing that seems so impenetrable by anything, no cures yet, and we're finding exercise really helps. And again, if here's a graph, right? From your perspective, maybe it reads this way, where we have decline of some type over time, right? Time and decline. With Alzheimer's disease, memory, and maybe with a progressive MS condition, you feel like the decline's like this. Okay? If you exercise, we're not saying you're going to go like this, back to when you were 15 and you could do 100 pull-ups and sit-ups, right? But what we are saying is, instead of progressively declining at this rate, why not progressively decline at a more steady, even rate? Yeah, we have some decline. Yeah, we lose a little, and it's tough. But it's a heck of a lot better than that. Right? You get that point. It's an easy point to make. The problem is when you are declining, no matter at what rate, as you said earlier, it's hard to see that that's good because it's still a decline. It's only until you can compare your possible self of declining like that you realize, oh, that's much better. I like that. I'll do that. And these things, again, adopt them because they won't cure you, but they will help your overall well-being, and do them as tolerated and as indicated by your doctor. Don't over-exercise. All right. Take care of caregivers to avoid burnout, seek professional help. Caregiver support groups. We had a couple of folks up here talking about support groups in general, and I was out of the room for a second, so I didn't know if they referenced caregiver support groups. But I'm going to give you a slide at the end here. This is huge and essential. Do not think you don't deserve it, caregivers. Don't think, oh, it's not for me, I've been managing well. Please. The resources, the relationships, the connections you can establish to help you and your loved one with MS, through things like groups are amazing. And oftentimes, folks will come out of a course of a support group and say, day one, I never thought I would have liked this or gotten it. So you're not alone if you have that feeling going in. But trust me, it's useful. Again, just a take-home point here. Remember, a diagnosis of MS is not an individual sentence to misery at all, but rather a family challenge. And we're asking you to rise up together. These are basic ideas, guys. If you've got a burden, if you've got a weight load, carry it with the two of you rather than with the one of you. Right? Makes sense. And teamwork came up again. I don't know why, but allow someone to sit on you once in a while. I guess is the good point. This is a great book, and I have no relationship. I didn't put one of those disclaimer statements in the beginning or end of my talk, but I'll just tell you, you have to trust me. I could give a couple of books. This is good because we're talking about multiple sclerosis and families. It's a great guide, very readable. If you go on to check out Call book here, also check out others. Again, I have no relationship to this person. I did read the book, and it's excellent. I don't have any copies with me, so I have a picture of it. It's in my office. Also, MS Views and News. Hosting, had to put the website up here. You got it all over your paperwork. You've probably all been there because you had to register. But I'm finding this. I'll be an honest consumer of information and tell you I'm not on the website in any way as a director, member, or anything. So as a consumer, this is, am I right to say, Stuart, this is growing vastly in terms of the resources you have available on there. From when I first saw it over a year ago to where it is now. One of the features of Stuart's website that I like are the articles. Now that you have going down the middle, there's articles on almost every subtopic. So what you didn't get from Dr. Isa and myself here today, go online, click on an article that you're interested in, and get a quick update of what's going on in that area. And then support groups are my big thing, both for patients and family members, okay, and caregivers. Multiple Sclerosis Foundation's a decent website, and what I found on this one is a listing, and many of them have these now, where you can go into your locale and you can click and then find a running list of local support groups. This one I looked at more recently, I think about a week ago, and it lists some of the ones you actually mentioned, covering, if you do Central Florida, it's got Orlando, DeLand, Lakeland, Lake City. I've seen stuff going on, certainly in your catchment area. It won't be too far of a drive. So I think that's it for me, and I know we're going to shift into a Q&A for a little bit. Do you want to transition us, Stuart? Or?
Absolutely.
Okay.
I like to talk. So, firstly, I want to thank Dr. Konitzer. This was... I want to thank Dr. Konitzer. This was a great subject, and we're being asked by people in many places. Again, the evaluations that we ask you to fill out, we don't know what programs to bring to you unless you fill out these evaluations. So, you know, if enough people in this room respond about a subject that we've never done before, then that's something that we're going to bring to you in a few months from now. So again, you know, we do need you to fill that out too. But again, this was a great subject to have both of these speakers. I want to thank them both. Before we get into the Q&A, I do want to thank them from my heart, because this is one of our better programs this year, and I do thank you. Now, gentlemen, if you'll come forward inside the box. Okay, you have to be in the box. Everybody, what we're going to do... Say that again?
It's like a game show inside the box.
Yeah, inside the box. So everybody, if you're afraid to actually ask a question, then we could give out little notepads or whatever. Just write it down and then raise your hand and somebody will come and pick it up. Otherwise, Nida is right here and she's got the microphone, and we would like you to state your question so everybody could hear it. Do not worry, we are not videotaping you. They will only hear your sound. Okay, so you'll ask one of the doctors to answer, and one of these two will share this microphone. Thank you.
Stuart, can I add something, adding to the doctor? In addition to the MS Foundation, you also have the National MS Society that they can find support groups because some of them are in this foundation, others are in the society. So there is information outside, so you can find their website also. Just want to add it to the information because I'm a support group leader and I believe it helps us a lot. We have a question here.
Yes. First of all, I'd like to say thank you to you both, and I'm sure all of us feel the same for taking time out of your Saturday to come speak with us. One thing, I don't know if it's really a question, but you spoke on processing information slowly. I have found that, I think someone gave the 10 times 6 divided by whatever.
She's going to answer.
I don't even bother anymore to even try. And I know that's not good, but I do. And I'm just wondering if you have any advice to get me back on track. Because I know it's not, but it's like, why bother? I know I can't do it and I don't bother. Maybe you have some advice. Thank you.
Yeah, so just real quick, just a follow-up question to you. What are the things, just in a nutshell, that you don't bother with anymore?
Such as anything that I have to physically think about. and yeah, and it's I think it's become maybe laziness rather than the MS is, I don't know. I mean, anything that I have to think about is like, I'm not even bothering.
So it sounds to me like what you're saying is because of an initial struggle with it, you've kind of made a conscious decision to, I'll let that go. And then that in letting it go, when other prompts come for you to have to process information, you're not even stepping up to the plate, right? And so my advice would, and it's hard to give out too much advice, especially in my discipline for psychotherapy, because I need to get to know you and meet you. But general advice would be I understand you. I understand why you would take that perspective. But maybe not throwing in the towel so much might get you closer to realize your slowness in processing doesn't leave you out of the ball game. So just because it will take you a little longer to respond or give an answer at times or execute a task doesn't mean it's worth giving up on the task and the interaction altogether. Does that make sense? And you might find you get some of that motivation back if you allow yourself to play the game a little bit. Yeah.
Hi, this is my first time. I just came from Puerto Rico this last August. And I came because I'm raising my own self in a new medication. I was in Tisabri, 78, 79 infusions, but they gave me a lab test and I gave positive on the virus. So now, I hate needles, I really do. Believe me, I do hate it. Sometimes I can really bite a nurse. I get crazy, yes, because I got asthma. I don't got too many veins.
Sure.
Now I'm using Tecfidera. All the flushing, enrojecimiento, everything like that.
Thank you. Thank you for that word. Thank you for that word.
I already passed through.
Right.
It's supposed to calm down after the 90 days using the Tecfidera, and if you use the medicine with food.
Right.
My own experience. But I used to take 11 pills per day. I always in pain. I got hernias disc at the neck and the lumbar. And it's getting me crazy because I always am in big pain. But they made me a test, a lab test, and said I got problems with my livers. So I cut out the painkillers. And not taking more baclofen, no more Neurotin, or Garapentin, that's the way you say it here. No more Cataflan, no more Flexeril. I cut it all. And I asking you, can I take some vitamins or health supplement to help my liver? And if I do so, can I have something that can help me with the pain? because I don't sleep at night. I just sleep 3 hours per day.
Right. Right. Well, I mean, it's always, I think one of the difficulties with some of the question and answers is trying to provide you some help without really giving you specific answers, because I don't know your whole story. So in the short term, I'm not aware of any supplements that really, quote, helps your livers. There's a lot of people that propose a lot of things, but I don't know if there's anything that's definitely proven for that, number one. Number two, I think with your doctors, again, we talked about it earlier, you just have to find a way to balance the meds you're taking with the pain that's being, relief that's being provided, and then ask yourself, would maybe like a physical therapy program, a conditioning program. I think that a lot of patients with spine problems do better with a therapy, an exercise program. That'd be one thing to consider. And then instead of being on 4 different drugs, which often happens, you're on 4 different drugs, each like at a medium dosage, try to work with the patient to pick maybe 2 drugs and max out those dosages with a goal ahead of time about what do you want to do that's reasonable, and see if that works over the next 2 to 3 months, rather than, which I see is, like I said, is these sort of mid-level doses, 5 different drugs, and you might be better served to just pick 2 drugs and say, I want to be able to, go out to a movie with the family, or I want to be able to go for a walk or something, and come up with some idea of what you're shooting towards, rather than taking on this big monster of pain, whatever that means, and making it become less, because sometimes you don't, there's no way to do that, really. You just have to, I think you manage on pain management, for me personally, has to be more of a functional approach. But,
I lost 24 pounds.
well, that's wonderful. That's fantastic. Yeah, you're doing all, yeah. But right. Well, I would try to simplify your meds, pick a couple, and come up with a goal that you're shooting for, and then. But I'm not aware of anything that's going to make your liver better. But there's never a simple solution for pain management. But you have to come up with some ideas.
Dr. Isa, kind of adding, and I know you maybe doctors, I don't know if you don't like it too much, is natural medicines, is
I'm okay with
alternative,
it.
is
Yeah.
another choice. I mean, she may have to, maybe
Absolutely.
she can look into
Yeah,
it.
absolutely, sure.
There is something that supposedly helps the liver that is natural as milk thistle, but we as MS individuals
We're not supposed to take it, yeah.
can't take it. But we do have an individual that we can refer you to talk about supplements, because you can't take it by yourself. Go ahead. Sorry.
It's okay. I actually had 2 questions. My first question, the whole memory thing. Oh my goodness, that has been horrible for me. What does it mean when you think one thing, but the words come out completely different than what you said in your mind? Like that, like I'll raise my hand in class, I know the answer, but the word that comes out is
Yeah.
not the answer. Like,
Yeah.
I don't know.
And more importantly, what do you do to cope with that in the moment, and then next time, in preparation for next time you want to do that?
True.
Honestly, that could be due to a whole host of different issues. You're talking about a language-based problem. Perhaps you're reaching for a certain word, and there's a spot in your brain on the left side that interferes with that word, and some other word comes out. One strategy I've worked with a younger person on a similar situation going to college was to write down what they wanted to say before they said it. It wasn't only for asking questions in a class and not wanting to be identified or embarrassed, but also for giving a presentation. Okay? And just use, more generally, I'm going to say, and answer your question, what we would call compensatory strategies. So for the things that seem to be consistent for us, that aren't relieved by a medication or by another strategy, we need to do a workaround. We need to compensate for that weakness. And one of the things you might try doing is writing out what you want to say, visualizing it, and then if it's the wrong word, it came out wrong in writing, cross it out, write the right one, and then just read back
Okay.
what you're what you're trying to
been many
trying to
days in
write.
class.
Yeah.
My second question was the little picture of the man with all the symptoms and like the percentage. Say you have like all of those symptoms except maybe 1 or 2. Does that mean you have a new lesion? Like, does that mean lesions are active, or is it just? It's really weird. Like, I have all those symptoms.
Right. So I don't think that there's a tight correlation. And Dr. Konitzer was talking about cognitive impairment and lesion load on the MRI. There's a bit of a mismatch. So there's a lot of things that go under the radar that you can see on an MRI scan with brains of patients with MS. So it might be that that's part of what's going on with you. So that that could be part of it. And then again, back to my previous points that it's always important to at least think twice. And is there some non-MS explanation for at least some of those symptoms that might be something you can address? But the MRI doesn't always correlate to the amount of symptoms that the patient has in both extremes.
Let me just add one more quick point to that for anyone, because I think I would get into the game of looking at my lesions, lesion load in specific areas on mapping. And with neuropsychology or brain behavior relationships, Dr. East is making a great point. We used to think there was a one-to-one correspondence between a brain area and a function. So speaking the right words, this area, okay? And it's true to some extent. There's some areas of the brain you have a lesion, most likely you're going to have the symptom. The problem is the brain is so complex and requires so many activities and elements to execute a single behavior that you could have a lesion outside of the language area, okay, but you're unable to produce words accurately because the lesion is in an area that helps you grab the word you want to use and then put it out through your mouth through the world. So, in other words, two different lesions in different areas might cause similar or the same symptom. It's very difficult to brain map, especially with MS, because we've got things popping up here or there and things dissipating. So I guess I say that don't get too hung up in the game of looking at your own scans and saying, oh, Lord, this is what I have to deal with now for the next month.
Thank you. My name is Susan, and I was diagnosed with RRMS 13 years ago. And I just had my my second relapse. I hadn't had a relapse in over 12 years. And I got a urinary tract infection in August, and I had the worst exacerbation. And I was hospitalized, and they overdosed me on Medrol. I had a heart attack and a blood clot, and it was just a nightmare. And my question is, I turned 50 this past March. I'm an advocate for therapy, and especially Copaxone. I love Copaxone. It's worked great for me. And how I have heard, and I don't know anything about this, that after the age of 50, the therapies may not be as effective, and that I may not even need to be on a therapy. Is there any truth to that?
Let me see. Right. So it is, I don't know that that's a definite truth. I think that it is shown in some studies that people with MS can progress faster after the age of 50. In other words, that curve, that slope decline, the slope gets a little bit sharper after the age of 50, almost independent of how well you were doing beforehand. And I believe that there was recently a recommendation to consider not treating if you've over the age, I think it was like 65 or 60, and you haven't had any relapses or stability over the last 5 years. The idea there being that these drugs are primarily anti-inflammatory component of MS, and then there's sort of a second component of MS where you get some degenerative changes, and these drugs may not be as effective for that. I wouldn't say that's like some national guideline or policy, but there has been some articles written about that, and there have been some observations in population studies where they look at big MS clinics and they see how people track, and there is a tendency for sometimes things to get worse over the age of 50. But if you had a recent relapse and you still have evidence for relapsing condition, it would be reasonable to continue your therapy. But those are some sort of evolving ideas of how long do you keep somebody on MS drugs, since the trials were designed primarily with younger enrollees who had more active recurrent relapses. And so as you progress into your 60s, should we keep everybody on a drug? And some of those answers are not out there because the trials were not designed to answer that. So people are trying to look into that now because it is a lifelong disease.
Do we have anybody on this side have a questions? Everybody? Okay. It's for recording. No, it's for recording.
Oh, okay.
The question.
Okay, I've heard it works like if your MS has been stable, like with no relapses for like the last 3 to 5 years, that after you turned 50, that it would generally level out at that point.
Well, what I've heard is that it is likely that you'd have to start to notice some decline when you look at a population over the age of 50. If you look at the rate of progression of disease, of impairment, disability impairment, it tends to get a little bit greater accumulation after the age of 50 than before the age of 50. Those are, again, those are sort of population observations. You get 400 people in a big clinic at a university center, and they go back and they look at how Mrs. X and Mr. X do, when they were 40, when they were 50, when they were 55, and they try to plot it somehow. But it's not, that's not data that you use ahead of time to help decide for the patient. So you don't, yeah.
Any other questions around here? I just want to kind of help, I can't remember his name. You see?
Dr. Konitzer.
MS moment here.
Dr. Konitzer.
An MS moment, I'm sorry. I just want to kind of back up what he's saying about the support groups. It's like he said, a lot of people have a misunderstanding of or misconception about support groups, and it's very helpful. Like he said, when some of them, when they walk out, is a very different experience. Also, I heard other not nice experience, but that's why you have different support groups that you can try in your area. Just look for information, look in the websites, and then participate. It's nice. It's help us. Any more questions around here? Oh, one more.
Really two. One was in regards to clinical trials, and because people are living a lot longer, shouldn't there be some focus in the future on looking at clinical trials for the older person who's living with MS?
Well, yeah, absolutely, there should be. Clinical trials are driven by two big categories. One is going to be pharmaceutical funding. That's where you get a certain amount of revenue from that, money for that, to be able to do these trials. These are very expensive trials. Tracking people is a lot of work. And then NIH funding. Unfortunately, because of recent changes, there's been an ever, reducing budget for NIH funding. But yeah, that of course, that goes back to the question before about how long to treat somebody. And is there a point where maybe these therapies may not be beneficial because they weren't studied for 20 years? But it's very difficult to do a study and track people for many years, 5 years, let's say, or 7 years, without a lot of resources. It's very resource intensive to do human trials.
And the second question is, what's your thoughts on using Botox for spasticity?
Right. So I use Botox for spasticity, not infrequently. I inject Botox every week in my practice for something or other, whether it's headache or whether it's spasticity or dystonia. And it can work very well. Again, you sort of meet the patient and decide what are your goals with the treatment, what are you trying to shoot for, and it can work very well.
I think he has a question, the doctor. He has a question in his hands.
Yeah, sometimes it's easy to write your questions down easier. So I've got one here. I hope I get this right. I have a 12-year-old and a 22-year-old. They have problems with exception. Mom has MS. They say I'm the strongest person they know. So it sounds like the kids really look up to mom, right? I just got a lift put on my car, and they are kind of embarrassed, right? Okay, yeah, back to that bullet point that gets me a lot of questions that people really don't think about often until it happens in their lives. We forget about the kids, and what are they going to think when they have to bring friends over or go to the grocery store with you and you have your new lift on the back of your car? What do you do? And I'm gonna throw this answer back on you real quick. Any thoughts? This is like a mini support group now. You can see the power of it. When someone else has already dealt with that and they can tell us, what do they do? I have my answer, but I'd love to know what someone else has done or would do in that situation. Yeah.
Make it fun, funny, because my friend's mom has a similar situation, and she pimped out her wheelchair. It's awesome. Her wheels spin. And so it's hilarious. When we see it, it's hilarious. We're like, you go, girl.
Right.
That's a good one.
Right. Yeah. The individual with MS, and you know, we all vary as humans, but you have to have enough confidence to be able to address this. Maybe take a deep breath. Maybe you cry a little when it first happens and you go away and decide how you're going to come back. But that's an excellent. Let's make this fun in some way. We pimp it out, get the kids interested in it, you know. But I would say, above everything else, whatever it is you decide to do, talk to them about it. It's a simple answer. Talk to your kids about it if you notice. Maybe wait for the right moment. You got the skills of being a parent through many years of experience, right? Maybe not impulsively in the moment cause a scene. Notice it, you know, take it with you, think about it, take them home, and address it head on. It can't hurt, it can only help.
Okay, we have one here.
Yeah.
As do you guys have anything coming up with involuntary tremors? Is there anything for it? Is there anything for involuntary tremors?
Well, it depends on the type of tremor. I don't think there's anything specific that's new and being targeted just for that symptom. We borrow, as I mentioned before, in neurology, we borrow medications from other camps to treat symptoms, and so typically anticonvulsants or benzodiazepines, which are drugs in the Klonopin, Valium family, can be helpful. Seizure drugs can be helpful. And depending on the tremor and what you're trying to target, even, again, all this is off-label, but even botulinum toxin injections can be helpful depending on what you're shooting for.
Okay, we have one another in this side.
I don't think he's done.
Oh.
He had another.
Oh, you have another question? Oh, I'm sorry.
They cut me off with no scissors. See, now I forgot. Now that's...
He's having an MS moment.
No, I don't. You can go.
Okay, so when you remember, call me again.
I just had a general question in reverse to having MS and then telling it to your children. But what if you are the child and your parents have to deal with a child who has MS and they don't really know how to take that on? And I don't know how to quite explain it, but it's kind of like, how do they, or how can we, I'll use that's where I should talk. It's almost like, how can you get them to understand your walk when you can't even understand it yourself, if that makes sense? Am I making sense?
Yes.
Oh, okay.
Oh, no, go ahead.
So it's, you know, because when it came up to the whole question of caregiver, and it's like, wow. So not only do I still have to be a caregiver, because I'm already a caregiver to begin with, and not just because my parents are sick or anything like that, but that's just the role that I've played. But then here it is, I have this lifelong illness, and it's like, oh, wait a minute, so I have to be caregiver to myself too, because my family doesn't know how to do it, but then I still have to advocate not only in society, but in my family as well. So then it's like, okay.
Yeah, that's a complicated question, and I hate to, like Dr. Isis said, give you a generic answer, but I think the more meaningful, powerful answer would come from you and I one-on-one, maybe through some counseling, right? And so first and foremost, I have to make the plea. I think everybody, whether you have a chronic medical condition or not, could benefit from family therapy. That's my bias, right? And I think in that context come solutions, you know? So you and I could talk longer further, as long as it's, you know, ethical and not too deep. But, you know, I think getting yourself in an arena that you feel comfortable in, professional or just within your family, and sharing how you feel and what it means to you physically and practically. You don't have to know all the ways to explain it perfectly to everyone, but simply that you're burdened and you're a caregiver to yourself and to them. And how do we work this out? How do we distribute the burdens in this scenario so that everybody maximizes their overall health?
I was just going to add something in a slightly different scenario, but because of our MS practice, we see this a lot with women, are a big part of our practice, mothers, sort of head of the household, so to speak, and the dynamics of the house. So when they come down with MS, and they feel like I got to worry about my MS, I got to worry about my kids, I got to worry about my spouse, blah blah blah. And I'm not a psychologist, but I try my best to try to empathize with all my patients. And what I tell them is, I'm sort of more kind of bottom line. I'm like, well, bottom line is they need to just kind of step it up and stop asking mom to, do everything all the time. And if they're big enough and strong enough and older enough, that's maybe not a very psychologically sophisticated answer, but part of it is they have to find a way to, take that role off of you. And maybe your parents also have to understand that, there's, like you said, he said, you're overburdened or someone's overburdened, and everybody needs to start changing their roles and their expectations and not get stuck in the old ways, because the old ways are done. And now you got to think of a new way to think about the household. And so I deal with that more, trying to support my patients with the younger kids and the expectations of the younger kids and the spouse when they don't change their ways. And so I think this is a great idea about looking at it as a family, condition rather than the individual.
Caregiver.com is a good resource. I know it usually just gears towards seniors, Alzheimer's, whatever, but they have so much other information for caregiver.com. They have lots of topics that can be brought up in there, and I know that I have brought up the same situation when I went to a meeting that, okay, I've got the MS, mother has the Alzheimer's, okay, how do I do this? And it does help to just bring those up, because you have another group of people that can help answer those questions.
What is the website again?
Caregiver.com.
Caregiver.com. Well, thank you.
Thanks.
Yeah, so I hear a lot about disease, like prevention of disease progression, but what about disease cure? Because I never hear anything about a cure. Are we anywhere close to it?
Oh, you get a tough one. No cure yet.
Give a short answer, no. So I can give a very short answer, no. So I could sort of mumbo jumbo it, but the bottom line is no. It's a complicated biological, process, and there's not like just one thing that's going to need to change, and so I don't see that there's an immediate cure down the road, but I think that there'll be more and more substantial therapies that will have an impact on halting the disease progression.
I have a question I think both of you might like to answer. As a parent of young adult children, I'm probably older than most of the people here, so I have young adult children. And I worry constantly about passing my MS on to one of them or several of them. And how do I let them know that I want them to be concerned about themselves but not overly concerned? Do I have to, I've encouraged them to test for vitamin D and to take vitamin D. What else can I be doing to encourage them but not frighten them? Yeah. Medically and supportively.
Well, that is a good question. I don't know that I have a great answer for you. I think part of it is, if you have a genetic, there's pretty good evidence that there's a genetic predisposition to getting MS, and that that you sort of have a predisposition to develop it. If you have a genetic predisposition to it, it doesn't mean you're going to develop. It doesn't mean the children are going to get it. And I think all you can do is just I tell the families, all you can do is sort of be aware of that possibility, and these are symptoms that one might see with MS, and if you develop them, it'd be worth getting checked. But it's not like a 50% chance of them coming down with MS. It's not like a Huntington's disease or something like that has a strong, genetic predisposition. The other concern I have, though, about worrying too much about that is that you don't want to sort of ruminate, sort of think all the time about something that may never happen and burn a lot of psychological energy. So I just say you just educate them. This is what you would watch for. There's a small risk that you might develop it. on the flip side, right, there is nothing else you can do about it. If you're going to get it, I mean, right now, if you're going to get it, you're going to get it. And so I don't know what the point of, getting too concerned about it is, but.
Yeah, and just to quickly add to that, I feel the same way, you might not like this part of this answer, but I'm so hung up on the dynamic piece with chronic illness, with the family dynamic. Even if someone were to tell me they have no family, I'll give you a family and we can still talk in that context. You might consider talking openly with your kids and asking them what they want to know, to do, to consider, to think about too. And I don't mean to sound harsh like that, like take it off of you and turn the light on them. But in that network, everybody should get equal weighting, because everybody's going to end up supporting everyone if it's the ideal that I'm thinking of. So instead of saying, what do I need to do to prepare them, set them up, make them be proactive, you might bring them into a conversation and say, here's my condition, here's what we know about heritability, which is not much, but it's not a huge risk. Right. I think it's not a huge risk. Jimmy, Sally, are you concerned? And then if they are or aren't, what do you think you want to do? Would you like me to share with you, certain things that I go through or have, or would you rather not, and we'll see when we get there, kind of thing. So make it up to them as well. Why have the extra burden on yourself of trying to figure out how to protect your kids against something that you really don't have control over?
Okay, we have another question here.
Somebody had mentioned Botox for spasticity. Now with the Botox, does that, because I've heard that it doesn't necessarily last, it's something you have to continually redo and redo.
Correct.
If that's correct, is it a problem with the insurance that you have to redo it and redo it and redo it?
Right, so generally Botox is active in reducing your symptoms for depending on the patient, a couple of variables, between 10 and 14 weeks. So it's certainly not super long, but if it works well for you, every 3 months is the average. That's pretty standardized for, many years now. We've been injecting Botox well over, probably, in practice, 20 years now. So there's no surprises from the insurance standpoint. We have a very active Botox clinic, and I've been injecting since I was a fellow, back in 97, 98, and I've never had a problem really not for that type of problem of spasticity.
Any other question around? Okay. One more back here.
I feel compelled to give some advice. Do not depend on hints and innuendo to get your point across. Early in our marriage, I came home from work one evening. I found this carpet sweeper in the middle of the living room floor. And being a loving, caring husband, I thought she was very tired, so I put the sweeper away for her. The next day I came home and the sweeper was in the middle of the living room floor. So again, I caringly put the sweeper away for her. About a week later, I found I misinterpreted the innuendo, and I was supposed to be running the sweeper.
That's funny.
It's been my job ever since, and I do it all the time.
That's funny. Huh.
Story's gonna kill me with this one, but I want to share experience with I have 32-year-old daughters, and my mom is going through memory loss. And my personal experience has been that when they see me active, like you are doing, it's kind of give them a little bit of peace, even though they may have a chance, but they understand a little bit what I'm going through. And when they see me moving, it's like, they feel a little better that I'm active. So it's something I can, recommend is just keep active, keep doing what you're doing, and keep learning.
And remember that using a mobility device does not mean that you have given in to your MS. It means that you've learned to accept it and continue with your quality of life.
One more question? One more question, anybody? Do we have more questions? Okay, I guess we have. Thank you, guys. Thank you.
All right. I thank again everybody for coming out here today. And You know, I see some of the questions that are being asked. I see some of the topics being discussed by each of the doctors, and it also tells me what we're going to be doing in the future in the Orlando area. And I can't wait to, again, do our next symposium here, which is where we had a lot of people in this room were there for it when we began this early last spring, where we did a large symposium, multiple speaker program in Orlando with multiple topics, and I was writing notes while everybody was talking, and I think I want to have the psychologist and a urologist and a neurologist and a otherologist of some sort. Maybe a stewologist. You could figure out what's going on in my brain, all right? But before we go further, again, I want to again thank all of you. I want to thank the doctors. Thank you very much. I want to thank the MS Views and News staff persons that help out with this program and come up with the ideas to do programs. And we're winding down our year. That's a New York thing. We leave off the R's, and I got rid of that a long time ago, but it seemed to have snuck up on me. We're going to have a quickie raffle. I left the satchel over there with the raffle tickets. Say that again? Say it in Spanish? ¿Cómo? Yeah. ¿Cómo? All right, so we are going to be doing one raffle prize. First off, did everybody fill out your evaluations? Thank you. And by the way, remember what I said I had to do at the beginning? It's back. Okay. So, again, we have a tablet that we're going to give away. And I would like somebody to select Dr. Issa. There you go. Thank you. Thank you. It looks like I got that from, like, nowhere, right? Because the video camera only goes to here. And, you know, it came in from the outside. 8, 8, 4, 3, 7, 2. There you go. Thank you. Again, everybody, listen. That lady that's standing in the corner with the yellow sweater on, please give her your evaluations as you exit. Thank you again for coming down. Madeline's going around the room picking these up as well. I thank Madeline. I thank Nida. I thank everybody, again, our supporters, our volunteers, and of course the patients and the doctors for being here as well. Thank you, everybody. It's been a great year, and we look forward to doing this again in 2014.